Okay. Welcome again to the Train the Trainer podcast, and where I try to bridge the gap between science and practice and science in the fields of policing, use of force, and medical teams, and performing under pressure in acute medical simulation situations. And today I'm talking, and I have to put on my glasses, to Christopher Hicks, MD, and he is emergency physic and trauma team leader at St. Michael's Hospital, an assistant professor, Department of Medicine, University of Toronto, and co-founder of Advanced Performance. Thank you so much for talking to me.
Oh,
And
thank you so much for having me. Thank you for the invitation.
yes, and I became acquainted with your work because you wrote some great articles like Zero Point Survey and so on. And we had a lot of inspiration from your work in developing our programs here in the Netherlands for performing under pressure. So,
Awesome. Thank you.
and I
It's
talked with
wonderful.
some of your
Wonderful to
colleagues.
speak with somebody that has such a background such as yours. It's always interesting to talk across disciplines. It's
Yeah,
so much we can learn from other high performance, high reliability organizations.
absolutely. So before we start, what does a typical day looks like in your medical profession?
Oh boy. I do full-time emergency medicine. Um, and trauma is maybe sort of 2 or 3 days a month. So emergency medicine would be your standard shift. You show up, you do your 8 or so hours of shift work, and you go home. The trauma team work is on call, so that's anywhere from 12 to 24 hours on call in the hospital. And I'm realizing now, speaking from Canada, that the whole notion of TTL or trauma team leader is a bit of a unique thing. I didn't recognize outside of Canada that this was maybe not as commonly done until I spoke in particular with my colleagues in the States who had never heard of this role before. But for major trauma in Canada, it's kind of recognized, I think, across most trauma centers that the trauma team leader's skill set doesn't belong to a particular discipline or specialty. And in fact, most people who do trauma team leader work have a background in emergency medicine, not necessarily surgery, but TTLs can be from a spectrum of professions, most commonly from emergency medicine, trauma surgery, in some cases anesthesia. Um, and I think that is a nice nod to the fact that trauma doesn't belong to one discipline or one specialty, but it's a skill set. And so long as you have that skill set, you can be positioned to lead trauma teams. And so that's what the trauma team work entails. Then leading a team or a group of people in response to major trauma activations. And so that's most of it. My work as sort of an academic clinician, I think I've dialed down a fair bit in recent years, just because I need a little bit more sanity in my life. So there's less time as a protected researcher now than there was before. But as you mentioned, I've started a company with Andrew Petrosoniak, who I know you've spoken to before, called Advanced Performance, and that's where we take all of these little things that have always bugged us over the years about how systems are designed or poorly designed or not well put together, how teams are trained, how they're not trained, how systems are developed, and we've put all that sort of knowledge into a simulation group, what we call immersive design, that Andrew and I work on together, and that's kind of nice because it gives us a lot of freedom to go out there and address things like team performance and system development and environmental engineering and human centered design
Mhm.
within the healthcare domain, but also outside of that, and kind of do it the way we always wished it would be done where we work, so to
Yeah,
speak, without having to deal with a lot of the sort of the institutional bureaucracy that might limit some of the changes that we would otherwise like to see. So that's been kind of a fun sideline because Andrew, and what our background entails, and I'm sure we'll chat a little bit more about that, but that's given us a mechanism to sort of take all that and make it practical and share a lot of that work and that knowledge with other groups.
yeah. And before we started recording, you talked about how you came from a more psychological skills training background, and Andrew more from a design thinking background. So
Yeah,
when,
our skills, I think, complement one another pretty
yeah,
well in that regard. I mean, we view problems very often in the same sort of way, but we come at it with a slightly different lens. So back my my master's training in health professional simulation had a focus on what back then we would call crisis resource management, CRM. And I think early on in that, I was very lucky. My master's thesis supervisor was Vicky LeBlanc, who,
Mm.
as anyone might know, has developed a lot of work in stress and stress preparation training and stress inoculation training. And she was one of the first people to sort of clue me into the idea that CRM is great in the sense that it provides sort of a language, and a way for people to sort of name specific team skills that they otherwise didn't have a language for, creating verbiage like, situational awareness and effective team communication and that sort of thing. But it doesn't really tell people how to actually make that happen, particularly in circumstances where they might be stressed or cognitively overwhelmed. And so my background was to say, okay, CRM looks fantastic, but how do you actually make that happen in high stress, high pressure environments? And that's where my interest in psychological skills training and stress preparation developed. Um, Over the years, and in part, working with Andrew has sort of shaped my thinking on this. He comes at it much more from the sort of environmental and systems engineering point of view. Um, and that is to say, rather than teaching people what the preferred behaviors are, try and make the preferred behaviors the easiest thing to do. In other words, design, an environment, a space, a system, equipment, whatever it happens to be, to make what you consider the safest and best practice within a team environment in a high stress situation the easiest thing to do. And you layer on things like CRM language, and you layer on things like psychological skills training and all of those things. But you make the environment as optimal as you can in order for people to be able to execute. And so when we look at a problem, we sort of have those overlapping viewpoints, and we kind of bring a shared perspective from a slightly different lens, and that's I think what makes some of the work we do together as effective as it is.
And what is your current view on psychological skills training? Here in the Netherlands, we developed a 2-day course, which
Hmm.
is mainly based on psychological skills training.
Hmm.
We, for the time, used Michael Lauria's his Beat the
Oh
Stressful
yeah,
acronym, like breathing, talk,
yeah, you
self-talk,
bet.
yeah, and so on. And but we use also the breathing and self-regulation and so
Hmm.
on, imagination and so on. What is your current view on psychological skills training in the sense that do you still use it? Do you still teach it? What is the value compared to more design interventions?
I mean, I think they overlap. And not to subtract the relevance of psychological skills training and development. I just think that they layer on top of one another. I think Cliff Reed talks about self-team environment system, which is something that in the 0 Point Survey we talk about quite a bit, and overlays a lot of the work that we do. You really need all of those things put together. That is to say, um, you have to develop individual skills in the context of the team that you're working in the context of the environment and the system that you'll be trying to execute in. The problem, I think, that I've seen many times over is that they're all divorced from one another. You get, somebody builds a hospital and puts a bunch of stuff in it. And then they plop a team in there with a bunch of team members and ask them to do something. And all of those team members have varied backgrounds and varied experiences and very varied knowledge sets, and varied capacity for things like stress and and performance under pressure and that sort of thing. They've all been developed separately, and they're expected to perform together. And that always seemed bonkers to me. So, the notion that self-team system environment all sort of gets developed in a cyclical manner. It's not, one after the other, but they should be developed in concert with one another. Um, my main, I guess, thesis these days for where psychological skills training fits in is it's part of a bigger picture, a bigger conversation, um, in the sense that they all sort of have to be developed with the other in mind, so to speak. And that's not easy, but it certainly does yield from my point of view much better, much safer, much more efficient outcomes. We do teach psychological skills training. I do use it all the time. It's still very much a part of my practice. We developed a simulation based course here, which back then we termed stress inoculation training. I think how that has shaped from what the classic Meekenbaum practice of stress preparation. I've learned to be, I think, a bit more flexible with how it actually looks, because experimentally, straight up boilerplate, scientifically organized stress inoculation training um, works great in the laboratory. But when you start to put it into practice, you realize that everyone is a little bit different and everyone is going to take different things from it. And I might find breathing exercises useful, but somebody else might not. I might use, cue words and trigger words, or do a lot of cognitive reframing, which is probably my most common psychological sort of skills preparation technique. And other people might not find that as useful or might do it differently. So I guess how my thinking on that has changed over the years, in addition to needing to sort of integrate it with a broader conversation on, system and environmental development, is also that people are incredibly individual and they're going to take different things from it. And if you do box breathing and I do triangle breathing, and other people just don't do breathing at all because they don't find it helpful, then so be it. There's more flexibility to it, I think, than perhaps we originally considered and that we originally identified.
And if you could give us a sort of advice and lesson learned on this topic. So we provide a 2-day course for medical professions, pre-hospital and hospital, and we do some scenarios. Our first step is
Mhm.
to recognize when the arousal is too high or too low, and then we have some regulation tools,
Yep.
and we practice it. What would be lessons learned? How would you do
There's
that?
your 3-step or 4-step process, right? Of identifying and then learning skills and then developing those skills in increasingly challenging environments. I think two things I've learned from that. One is the recognition thing is probably the most important
Mm.
because in one of the most interesting things I think we observed when we did earlier simulations with stress preparation training is you couldn't get and this is I'm speaking for the health professions here. It may be different in law enforcement or other areas where this notion is a bit more ingrained. But there was a failure to even recognize that stress might impact your performance in a negative way. And when you run a simulation and we had heart rate monitors and we had cortisol monitoring and of course video recording and all of those things that you can look at people's behavior and posture and speech and all of that, and you sort of point out to them, yes, it looks like you're pretty maxed out in this scenario. What were you thinking? Or how did not what were you thinking, but how did you feel? Nobody would acknowledge this stress response. Or if they did, they would say, yeah, I felt stressed, but I just ignored it. And that's very ingrained in the health professions in particular. You're not if you feel stress about something or you feel anxious or you feel overwhelmed, you're essentially trained not to admit it, or not to identify it because it's viewed as a weakness or a
Yeah,
shortcoming. And if you identify it, yeah, you're certainly not. You're told not to. You're taught not to deal with it. You're told to ignore it.
yeah,
Um, so by far the most challenging thing I think we came across, and in the end, if you do it right, the most useful thing is if you tell people, yeah, you're going to feel stressed, people are like, yeah, yeah, of course I'm going to feel stressed, whatever. The point that I think is important to get across in that first step in stress preparation training is you're going to feel stress. Here's what it looks like. This is how it's going to impact you. And you frame it, and this is something, again, I'm sure I'm telling you something you already know here, particularly with athletes. You frame it as a performance tool. In other words, if you want to up your game, you're not identifying a weakness, you're identifying ways in which you can increase and elevate your own performance. And so framing it in that sense to,
yeah,
when you speak to a bunch of people who are used to performing high already, that's a bit more of an appealing thing to them than the idea that, people do shy away from the notion that maybe we're just, we're going to talk about our feelings and we're going to share some stories and we're
yeah.
going to feel better
Great.
about it. Framing it as a performance tool, which is what it
Yeah.
is, tends to get a little bit more traction. The other thing I think that we identified, and Mike Laurie and I talked about this, and one of these days, if I can get it together, I think there's a publication in here somewhere, is what's actually stressful in a simulated environment. I think broadly speaking, um, the what I would call sort of the cognitive stressors or the cognitive dissonance that you can build into a simulation scenario that's meant to provoke stress, along with socioevaluative stressors, are perhaps the two most compelling things that you can build into a simulation scenario. You have to be very careful with both because they can be very flammable. In other words, you can max people too much in a simulation. Um, and I'll explain what both of those mean. But I can tell you what didn't work in the past. We would do scenarios with, for example, say an active shooter, um, and uh, the idea was that there was an active shooter in the building, and people needed to sort of move a patient from the emergency department to the operating room in a timely fashion, or the building was going to be locked down and they were going to be stuck, which is something that could happen in real life. But what we learned was, and we learned this from debriefing participants and also from looking at their stress responses, that it was very easy for them to dismiss that as just not real.
Mm.
Like in a simulation environment, you get a certain amount of psychological buy-in, provided that you build scenarios thoughtfully. But certain things like, yeah, I know there's not an active shooter in the building, people can just dismiss that. Um, now, in things like the attack course, where you're out in the field and you're in an actual crashed vehicle hanging off a cliff or whatever the crazy stuff is that those folks do, the amazing work that they do, but it's probably easier to get that sort of psychological buy-in. But we found in a simulation center there were certain types of stresses that people could just ignore, and so their stress response didn't go up. So in the end, there was really nothing to talk about. What was very provoking, and as I said, these things need to be dealt with carefully and thoughtfully when you're creating simulation scenarios, is the first one I named was cognitive dissonance or cognitive stress. So perhaps the most stressful scenario that we had in our stress inoculation training was a refractory VT case. So a patient that had a pulse, but they were in VTAC. They arrived with VTAC. Their vitals were crappy. There had been a medication error in there somewhere. Somebody had given a milligram of epinephrine because they were identified as being pulseless when they weren't. And through the entire scenario, the patient's vitals didn't change. Nothing changed. If they defibrillated or cardioverted, didn't work. If they dual sequential, didn't work. They gave medication, didn't work. Nothing changed. Patient didn't get worse. Patient didn't get better. And that, again, that could happen in real life, but it creates a dissonance in a simulation environment where people start to think, well, what am I missing, or what am I overlooking, or this should be working, but it isn't. And if you think about your own practice, I'm sure you can reflect on what that does to your head. If you're like, well, I've done this thing that ought to work and now it doesn't,
Mm.
that can be a very stressful and anxiety provoking thing, because then the next question is, why is it not working? What have I done, or what am I overlooking? What am I missing? The second stress that I think you need to be even more careful with when creating stress preparation scenarios is socio-evaluative stress. And this is one that Mike and I have talked about a fair bit, and perhaps one that goes ignored in health professional training in particular. Again, I don't know what the case is for other domains, but this is simply the stress that you get out of having people watch you and evaluate you and feeling judged. Um, and again, in the health professions, it's a very powerful one, because you go into a simulation, um, and if your general sense or general stress is that you're being watched by somebody, behind the glass who's evaluating you, um, you can actually undergo what's called negative learning. In other words, this is one of the things that Vicky had taught me back in the day. Whatever is provoking your stress in the simulation needs to be the same sort of thing that's provoking your stress
Yeah.
in the actual situation when you do it. In other words, the person who's sitting behind the glass is not going to be there in real life. So the stress response is going to be slightly different. So your ability to recall specific skills is going to be different. The whole sort of context specific learning that simulation is supposed to help you with could actually hurt you in this scenario. But if you build in socio-evaluative stresses into the scenario itself, if you build in, a difficult attending or a difficult consultant, or if you build in, stress created from, we had a case where the patient was, the son or the daughter of an executive at the hospital. They're the stress from that is realistic and from within the scenario itself. It becomes a very important and powerful thing to talk about in the debrief, because people overlook it. Again, health professionals are not inclined to talk about, the idea that they feel that they might be judged or evaluated. Nobody likes to talk about that. And so it's a good and useful thing to talk about in a debrief. And it's a very realistic and present source of stress out in the real world, out in real scenarios.
I have
So
to,
those two things,
Chris,
those two things are, I think,
yeah,
incredibly relevant to consider when you're building scenarios.
great. Ruben Verlangen will also join us now from Athens. He's now on a simulation course there.
Mhm.
Is it okay with you if he joins us?
Oh, of course. Yeah.
Yeah. He's an ambulance medic. Here's Ruben.
Hi, Ruben.
I think he's coming on now. I had him on from the Rocky Mountains even when I talked to Andrew or
Okay.
Michael. Well, he will join
Oh,
us.
right on.
But if I understand you correctly, uh, the cognitive and social sorry, this is a very difficult word. Social
Yeah,
evaluation
it's a
part.
mouthful for me too. Social evaluative stressors.
Yeah, are these are stressors which can become too heavy, but you can also use them as a stressor, isn't it? Well, what is
It's a
your
bit of
point?
both. I
Okay.
think maybe, I think Ruben's joining us again. Hi, Ruben. He'll get there
Yeah.
eventually.
Yeah, I will get there.
Um, I think the take home message really are threefold for me. One, when you're, and I'm thinking now about, the trainer side of things, the job that you do as a trainer, the job that I do as a trainer. I think you need to be thoughtful and deliberate about the types of stressors that you're introducing to the scenarios that you create. You need to know what they are. You need to give them a name.
Mhm.
Because again, I think, the most useful part of stress preparation training, stress inoculation training is just giving, making people aware of what those stressors are and then
Yeah.
trying to tailor something personal to help them manage it. So as trainers, we need to be cognizant of what they are. It's also helpful to know what doesn't work. And again, I can't tell you what doesn't work, but I can tell you, experientially, what I find it's easy for people to dismiss.
Yeah.
And if you don't provoke a stress response, then there's less to talk about in terms of debriefing and less to talk about in terms of training. And I guess to your point, the last one is understanding how to dial up and down the intensity, because the
Yeah.
other thing that I find happens, and I'm guilty of this too, but have learned from it, is you're building a stress inoculation scenario. So you like crank the intensity up super high and you make like the lights go out and there's explosions in the background and the building is collapsing and whatever it happens to be. You don't need to do all of that. Again, you can overwhelm people, which makes the point of the scenario kind of moot. Or again, one of the responses that people get when there's sort of too much going on is to just dismiss it,
Yeah.
which they can do, dismiss it because it's not real. So you have to have as a trainer, you have to have your hand on the intensity dial and understand what to turn up and what to turn down. And by far the one that I found you have to be the most careful with is the social evaluative stress. Because if people feel like, as part of the scenario, they're being put upon or they're being talked down to, or they're being belittled, even if that's, built into your scenario, people can react very, very negatively to that. And again, they will just sort of turn off and shut down and they won't be as participatory in the whole, in the debriefing process in particular, which is where you're supposed to have a meaningful discussion about skills development.
How do you tackle that? Because the way you organize in simulation, you see your colleagues performing. That's a fact,
Mm-hmm.
eh? So
Yep.
there's always the evaluation part because we look at each other. How do you tackle that? How do
Oh,
you make
I
it
think
safe? Hi,
I think
Ruben.
Ruben's with us.
Yeah.
A lot of this is just, I guess, your sort of boilerplate setting the stage for psychological safety. You'll never be able to subtract a socioevaluative stressor from the environment, but setting the tone with a pre-brief, helping people understand, that training is not evaluative in nature and it's for their learning and for their development. Um, the basic assumption that you hear from the Harvard medical simulation team about how we understand everyone is knowledgeable and well intentioned and doing their best and so on. In short, having a very effective pre-brief to
Yeah.
set the scene it is incredibly important. Um, and don't get me wrong, I'm not saying that you can't have some element of socio-evaluative stress as part of your scenario, or as part of your training. In fact, you should. But it's important to give it a name and it's important to make it part of the scenario itself rather than something external to the
Yeah.
scenario. Um, who you invite into the training is important. Who's allowed to observe is important. What people understand is being done with the information collected, if anything, is important. And then sort of just basic simulation etiquette in terms of making people feel comfortable and safe and understanding they can leave at any time and these are where the bathrooms are and this is when the break is and all of those things, helping to set those expectations goes a long way to clarifying that, or at least minimizing the notion that an external socio-evaluative stress is going to have an impact on what you're seeing
Yeah.
in the simulation itself.
Great. Hey, Ruben, how are you?
I'm fine, thank you. I'm calling in from Athens, so the internet wasn't that good, but nice to meet you, Christopher.
Awesome. Likewise.
Yeah.
Likewise.
What is it kind of for? Where are you, Ruben? What is it for a course?
I'm on a European Resuscitation Council Congress, so it's all about CPR, resuscitation, but also about education.
Okay.
Awesome.
So, Ruben, do you have, because you know me, I'm talking a lot, I have a lot of questions. Do you have a question in mind for Chris, which you want to ask him?
Yeah, very thankful to speak to you, and very nice work what I read about. And I know you know a lot about your design thinking, and I work at an ambulance service. I'm an educator, and we try to optimize our education for paramedics or ambulance nurses, but also not only on the technical part, but also on the non-technical part, but also on the, yeah, how do you call it, uh, the design of our pit crew, for example, for a CPR situation. And yeah, to do that, how do you do that ideally? There's not that much evidence. Can you help us to how do you optimize not only the technical part, but also how do you design your pit crew attack of a CPR patient? How can you do that effectively, and how do you train them?
I mean, I think you probably do it better than we do it in the hospital. You know, even the notion that you're sort of drawing from a pit crew model puts you, I think, a fair bit ahead of where we might be, you know, in a hospital setting. But I'll take that example and give you some I guess some thoughts on how we do it. So, you know, if you're talking about education on cardiac arrest training, you know, CPR training in the emergency department where I work, we touched on this a little bit earlier. The notion that they all kind of have to be developed in concert with one another. That is to say, you can't sort of give people a set of psychological skills, as Eric and I were just talking about. You can't tell people to breathe deeply and then go into a system where the ergonomics are not optimized, because you still won't be able to perform. So you have to help people build and understand psychological skills as individuals, and then put those into operation within a team environment, and then optimize the environment in order to make all of that happen. So what does that mean by way of example? You know, I think that the psychological skills in part we've kind of covered in a sense speak a little bit for themselves. If you're, you know, training to deal with a cardiac arrest, you know, what's that going to provoke in you? What stress response is it going to provoke? What emotions is it going to provoke, and how do you handle them? We've touched on that. From a team point of view, you mentioned the pit crew design. I do think you need to be mindful about how your team is set up, how your team is organized. That is to say, you know, team structure and can fairly drastically affect team function. One of the changes that we've made in the emergency department structurally to our teams to sort of facilitate, I think maybe what you would identify as a pit crew model, we would call a CPR coach model or a team co-lead model. So in the past, having an attending running the code, as we would call it here, it's kind of a dumb way to say it, but an attending who's running the code from the foot of the bed is really responsible for all decisions that happen, and everyone else is just sort of like the appendages that, you know, go off and do work, and that could be very cognitively overloading. So having a nurse team co-lead is a structural change that we've considered making and have been trying to implement at our shop, where a nurse team lead takes over a certain number of team coordination behaviors and also takes on the role of a CPR coach. That is to say, it's now that one individual's job to monitor timing of CPR, monitor quality of CPR. We, of course, have some more biometric feedback on CPR quality that we can use to coach people on effective CPR process, changing providers. So a very, I guess, subtle, but perhaps not so subtle structural change to the team from a one person to a two person model with a CPR coach. You're now taking, you know, psychological skills in this component of cognitive overload, and rather just saying, well, don't get cognitively overloaded, or, you know, reframe or breathe, you're saying, okay, structurally now we're actually offloading some of that cognitive overload to another individual, and then setting your team up for success in that manner. You then have to, not then, but along with that, then have to create an environment where that's actually doable. So for example, in our, I hesitate to call it new, we're still building our new emergency department. It's a little on the slow side, a little on the delayed side. But we have our acute area sort of set up and ready, and it's been in operation for a few years. But before we opened up, we did a lot of simulation work, sort of crash testing the environment to optimize ergonomics. Andrew and I are both fond of saying, you know, a real patient should never be the first person to experience a clinical environment. So before we actually opened up, And even going back farther than that, back when we're looking at blueprints of how resuscitation rooms are designed, we did simulation exercises and mock-ups and staging exercises to get a sense of how the room ought to be laid out. And then once it was built, did more simulation work to optimize ergonomics and design and equipment. And as you may have seen, we created things like the resus tower and procedure bundles and things that sort of, as we were talking about with Eric, make the preferred behavior the easier thing to do, the easiest thing to do. And I'll give you an example of that. One of the things that we developed out of some of that preparation work is the notion of a femoral art line bundle. So, in cardiac arrest and in cardiac and pericardiac arrest care, the notion of intra-arrest or peri-arrest femoral art lines is becoming more and more of a thing. So you can, separate low flow from no flow states and titrate vasopressors more accurately and detect early ROSC, all of those things. You can tell people that that's helpful. But if you have to go and find 10 different things and then come back to the bedside in order to do an ultrasound guided femoral art line, nobody's going to do it. If you put it on a portable cart with a work surface on the top of it, and when you reach into the cart, you pull out a bundle that has everything you need from femoral art line in it, suddenly it's a lot easier to comply with that preferred recommendation. So you start to sort of engineer the system to make the preferred behavior the easiest one. Now, I've described all that as a straight line, but in fact, it's not. It's a circle. And when you start to do simulation work to make all this happen, you're developing individual and psychological skills along with team skills, along with system and environmental engineering. And then, as I was saying to Eric before, I think it's sort of fairly stuck on this notion that it all kind of has to happen as an integrated cycle. They can't happen as separate pieces from one another. And when you do all that, I don't know if it's purely an evidence-based recommendation, but the overarching term that is supported by the literature is the sort of the notion of design thinking and systems engineering. That is supported by pretty good evidence to say that if you put all that together as a process from start to finish, you get a better, more efficient, safer, more effective end product. The whole notion of looking at sort of a safety 2 lens rather than a safety 1 lens. You're looking at regular operations as well as when things go wrong, not just when things go wrong. And so our take on all of that, our system, the system that we work in is by no means perfect. But I think we've done a fair bit of engineering work, and the tool that we use more commonly than not is simulation, to get a sleeker, more effective, more integrated model, in this case for cardiac arrest response, than we had before.
Great. And so how do I told my manager to invest all that time? Because I'm very curious and I'm very convinced that it worked like that, but seems to cost a lot of time if you do that.
It doesn't have to. Andrew was lead on a study called the Trust Study, where we were doing regular in situ team training simulations in our trauma room that were activated as regular trauma activations. So the team got a page, didn't know that it was a simulation or a real case, and they came down. And that took a lot of buy-in. And one of the particular things we got is, well, the emergency department's a busy place. We can't accommodate, everyone's got stuff to do. We can't accommodate this, simulation in our daily workflow. And the argument we would make back is, well, if our system is so constrained that you can't accommodate one extra simulated patient for 15 minutes out of an entire day, then we have bigger system problems than we thought. And if that's the case, then doing this sort of work is even more important, because if we're that maxed, we need to develop some strategies for flexibility. So we started making those arguments to say, one patient, 15 minutes out of any given day. The second part to that, and this, I guess, goes more along less research and education lines, but more quality improvement and QI research theory. The idea that you have to be able to show people gains from the work that you do. So you mentioned buy-in. How do you get your managers to buy in? I think if you do this sort of in situ simulation work, which is sort of the term that we use, which means, simulation within the actual practice environment. If you do that work, and then all you ever do is sort of write it up and put it on a poster and present it at a conference, nobody in your work environment is going to care, and they're not going to buy into the notion that it can actually affect their practice or their work. But if you do this work, you put all this effort into doing an in situ simulation to make the system better, you identify a few things that, everyone comes to work and they know it, it's a problem, and they can identify that it's something that bugs them about their practice environment. You name it, you identify it, you go and change it. And the next day people come to work and their day is a little bit easier because of that change that you've made. It's really easy to get buy-in for the next exercise as a result, because people say, well, this isn't just a simulation exercise for education. This actually made my work better and easier tomorrow. And again, I'll use the femoral outline bundles as an example. Once you create something like that, nobody has to run off in the middle of a code and put it together, and people hate doing that. So nursing CAs, or what we call clinical assistants, who are responsible for logistics, they're all much happier. The clinicians, the physicians at the bedside are much happier because they get the tools they want faster. Everyone goes, oh, that's a nice little problem that used to bug us and has now been solved. Great. And so you have to make it very explicit, that feedback loop and that comes from QI, again, more than sort of education. But you have to show people very explicitly the changes that you're making that make the work environment better and safer and more effective. And there's no easy way in terms of getting started, but once you start to do that, it is pretty remarkable how interested people become in the next simulation session, because suddenly you're making their life easier, not harder, and that's really important.
There's a great motivator also to do it.
Yeah, for sure. I mean, with the trust study in particular, there was a lot of eye rolling initially about like, oh, this is a simulated trauma scenario. But after 2 or 3 sessions, and when we started to actually address some of the headaches that everyone kind of already knew was there, but now you're giving a name to, now you're putting data behind, and then went out and started fixing those things. It went from, is this another trust session, to, oh, when is the next trust session? Because I have this thing that's been bugging me that I really want to work on, or I really want to develop. So that was a nice change to see.
Okay. Thank you very much.
Ruben, do you also have a question for our 2-day performance under pressure course on the top of your head that you want to ask Chris?
Yeah, of course, we started with performance under pressure because that's, I think, the missing link in education. But we think we do the right thing. But the most important question is, how can we make it more effective to not only, Eric always says, we don't learn a trick, but we want to make them a transfer to the real life situation. And I think that's the challenge we suffer. Can you give some, maybe some things how you do it to make it into the real world? How can you perform under pressure? Because we simulate, we train them with a lot of fun and but also some irritating and all kind of emotions. But the transfer thing is the challenging thing. How can you make the learning more effective?
I may sound like I'm repeating myself, so I apologize. But the things that I've learned that seem most relevant are understanding what stressors you're bringing to bear. That is to say, understanding what they are, giving them a name, and then telling people what those, maybe not necessarily before, but during a scenario, you're telling people what those stressors actually are. Both as a developer, well, in particular as a developer, it's important to understand what they are and to know what they are, so that you can design scenarios in a thoughtful way. So you're not just creating, it's nice to be irritating with your scenarios, and it's nice to have fun and have, really intense stress preparation scenarios. But if they're not really congruent to people's actual practice environment, then it becomes less relevant. And sorry, as we did touch upon that a little bit before, but being able to name things like cognitive dissonance as a stressor, or social evaluative stresses, or particular things that people are going to encounter, give them a name, discuss what they are, because as you know, stress is not a blanket thing. They come from different sources and they have different intensities depending on who you are and what you experience. And so I guess that would be number one. Number two would be understanding when to dial up and down the intensity of those stressors, because as Eric and I were chatting about, it becomes really easy for people to dismiss stressors if they seem either too intense to the point where people kind of shut down and won't participate anymore because it's too uncomfortable. It's not real anymore. And as soon as it becomes not real, it becomes easy for people to sort of dismiss it psychologically, and you don't provoke a stress response at all. So if it's too intense and it's too maximal, people are just going to check out and they won't participate. As you know, simulation just in general is, if you just run a standard simulation scenario of any kind, a standard cardiac arrest with nothing else to it, and you monitor people's heart rate variation and variability, and you monitor their cortisol levels, and you analyze their subjective stress responses, they will report some element of stress, maybe not to the extent that you want for training, but they will report something. You don't actually have to turn the dial up that high just because you're doing stress preparation training. You really don't. And I think one of the things that I've learned over the years is that it's really easy to turn up the intensity too high as a trainer, and then you kind of miss the point. You have to know your crowd. If you're working with a special ops team, those people are a bit more accustomed to high intensity, high pressure stress. For me, it's a lot of trainees, like residents and medical students. And again, you have to be mindful about how quickly and to what extent you turn up the intensity for that stress, and be prepared to dial it back if you think it's a bit too much.
I also have a question. Did in police training, I was used that in simulation training, you just let them find out their own solutions, and at the end you had a debrief. That was a kind of the model we used, and I think now with the ambulance we also use a kind of this model. So just let them, if they freeze, and we talk about it later on, and so on. But recently I became more interested also just in skill training, and skill training is what it is. It is skill training. So I think if in a simulation, in a scenario, we have told people, for example, this is one of the main points, we tell people don't rush. So whatever scenario, don't rush and, go right into the incident. Just if they only could pause and take a breath, or even without the breath, just pause and make a scan and break. Okay. But what happens? They don't do it even after even after we told them we did some practice. They don't do it. I came to the conclusion that I don't no longer want to run the simulation going on. I just want to pause the simulation and say, what was the best way to do here? It was just to pause a little bit. What do you think about intervening in a simulation? What's your point of view? Because there are different views on it. Some people say you have to
Yeah, for sure. I think it depends on what you're going for. I think if you're talking about if your goal for a simulation is to create, we're talking about stress preparation here. So let's say your goal is to create a high psychological fidelity scenario that people do for 10 minutes to provoke a stress response. And to Ruben's question, I think the other thing that's important is that you measure that stress response and use it. It's a very useful debriefing tool. You measure HRV, you can't measure cortisol in real time, but you can measure people's subjective stress responses. Use that as a tool to say, are you actually provoking stress, and are people's responses getting better as a result of training? But if that's the goal of your scenario, then it's probably more effective to let the scenario play out from start to finish, unless things go really off the rails and you feel you need to intervene for people's sort of psychological safety. Because as soon as you break that fourth wall and you step in and you interrupt, then you'll notice that response changing to some extent, and you're introducing something that isn't going to be there in the real environment. In other words, you as a trainer, and as we talked about, that might affect notions of transfer appropriate processing and state dependent learning and all of those other things that simulation is supposed to be effective for. However, if your goal is a specific skill development, let's say you develop one particular skill, like how do you go into a room without rushing into a room and crashing into a scenario, and how do you take appraisal of the global picture before you actually start doing things, like let's say you've identified that as a specific skill that you want to identify. It sounds like that's what you're saying. Don't rush in, take your time. Then I think a tool like rapid cycle deliberate practice can be very effective. And so that necessitates some interruption, right? And if you haven't, I'm sure you've seen this technique or heard of it before, but it's the idea that you get a certain way into a scenario and then you stop it. And you tell people you're doing this ahead of time. I think that's also important. So they know it's not that they made a mistake. You tell people, hey, we're going to go a minute or so into this scenario, and then we'll stop and we'll take a look at a couple of things, and then we'll back it up and we'll go again, and we'll stop and we'll back it up and we'll go again. There's a few different ways to do a rapid cycle program, either sort of backing up and moving forward again from the start, or just sort of picking up where you left off and moving forward. Again, it depends on the skill that you're developing. The whole idea is you're rapidly iterating and building on a particular skill. And that's been shown to be pretty effective as a tool for skill development. What you're going to interrupt in a certain respect is the psychological fidelity that you get from maintaining that fourth wall. But again, if that's not the goal of that specific scenario, you don't have to do everything in one scenario, right? So you don't have to maintain pristine psychological fidelity and sterility in the simulation room with every scenario if it's not relevant to the goals of training. And I haven't done this, but off the top of my head, one way to sort of bring the two together is to do a rapid cycle program. If you notice people just can't pick up on the idea of slowing down and taking their time, then maybe you start with that as a specific skill development. You do a rapid cycle, technique for 10, 15 minutes until they have it sort of a bit more ingrained. And then you put that into a full, simulation exercise where they have to integrate that with larger skills. That also plays off of the notion of, skill building and development that stress inoculation is predicated on. You're taking all of these big skills that seem a lot if you put them all together, and you're breaking them down into smaller parts and then building them up again over time. And I think it's very fair, as you suggest, to look at it as skill development in some scenarios and say, like, we're gonna take this little thing and we're gonna break it down into its component parts, and we're gonna repeat it until everyone sort of has a sense of how to make it work. And then we'll put that into a broader context, into a broader team scenario. I think they can be very effective. It's certainly effective when you're talking about, micro skills for a central line, or, from an airway point of view, taking them, breaking those things down into smaller components and then building them up again is a very effective way to get things done. And rapid cycle delivered practice is a useful technique to consider for that.
Yeah, we use rapid cycle. I think it's very effective for small skills or procedures. But what we also find out is that the problem not is they speed up. That's the common thing we see often. They want to speed up when the patient is deteriorating.
Right.
And if we want to slow them down, it's difficult to reach them. But what we find out is that you have to recognize your emotions. Do you want to speed up? And the problem is not to slow down. The problem is to recognize what you feel. And so our first goals in our performance under pressure training is to recognize your emotions and to stand still with what's happening with you. And people find it difficult to find words for emotions and
no, we before you
happens.
came online, I think we were saying arguably the highest yield element of if you want to call it stress inoculation or stress preparation training, the highest yield element of all of it, in my opinion, I guess, apart from just the skills development side, is just getting people to acknowledge that emotions are present and they get in the way of things. That's a tough thing for health professionals to do for whatever reason. We're just not good at it. So getting people to sort of acknowledge and identify that they're there is a big step, and it's a big win. The other thing that I'm trying to remember, if this was Vic Brazel or somebody else that talked about this technique, but we pulled it out at ResusTO and it was really effective. And again, you have to know your audience on this, because some people would find it a little bit silly. But if you're trying to compel people to slow down and respond in something that looks a little bit more like real time, or even if you're just training people to sort of pause and take a break, you give them some extraneous tasks to the scenario to necessitate the passage of time. In other words, we had people at a certain point break and they had to go and build a Lego set for 1 minute. They had to let that minute pass. And while you're building your Lego set, you can sit there and think a little bit about what psychological skills are bringing to bear and what emotions you might have in your head. It's more of a debrief tool, because you're forcing people to take a break. And then during the debrief, you can have a discussion with people about what it was like to sort of let that minute pass, and how torturous it was, and how difficult it was, and how much you wanted to jump back in there. And then what you did, from a psychological skills development point of view to mitigate some of that. But sometimes those forced pauses can be very effective. It doesn't have to be building a Lego set, but you can compel people as part of the scenario to take a break and to do something else for a little while before they jump back in. And during that time, give them some points to consider. Again, in this case, around what specific psychological skills and stress mitigation strategies they would implement in that particular scenario if they had to take a break, if they had to slow down.
Yeah. There is great research in the field of mindfulness. It's called meta-awareness. It's just be aware of. It's be aware of where your attention is, and both in special forces, Norwegian special forces. Christian Itterboll wrote a dissertation about it. That the most important thing, according to his dissertation, was to be aware of where your attention is, or you can also say where your emotion is. And that the awareness, only the awareness of this already, makes room for regulation strategies. And also in the military, and I'm not sure if you read the book from Amishi Jha. She's a neuroscientist. She wrote Peak
Hmm.
Mind, which is now
Hmm.
adopted in the American US Army, where they
Hmm.
also teach this meta awareness part, just to
Hmm.
recognize where is my attention and is it.
Right.
Yeah,
And I
and then
think
yeah,
when you say attention, I think that's the key phrase. The notion of metacognition.
yeah, exactly.
I have to go back a little bit because actually, even before CRM, my first kind of real interest in, I guess, what you broadly define as human factors was the idea of cognitive errors and cognitive biases. I found it really fascinating that, we all carry around these ways of thinking that are, some are helpful, many are not helpful and not adaptive. Um, things like premature diagnostic closure and short satisficing and things that lead to all of these sort of diagnostic thinking errors. A Canadian named Pat Crosscarry kind of wrote the book on that back in the day, and listed all of these sort of metacognitive errors that you can develop, and all of these heuristics and biases that we bring into the workplace every day. And he preached, as do others, this notion of metacognition is just, thinking about your thinking and understanding where you're likely to make errors. The problem with all of that is it didn't work. You teach people of what their biases are and where their biases lie, and then you go in and see if they can have an increased awareness and avoid those errors, and it doesn't seem to be the case, in part because a lot of the errors are subconscious, and it's awfully hard to be aware of something that's subconscious because by definition it's a subconscious bias, and so it becomes difficult to address. But what you're talking about is different, and this is more about where your attention lies, which is something that
Yeah,
you can be aware of. I don't know if
absolutely.
you're familiar with some of the work out of Kingston, which is just down the road from where we are in Toronto. Adam Sazlewski and his group. He's an NEM researcher on cognitive load and in emergency and trauma, and he does a lot of very interesting work with pupillometry and eye tracking.
Yeah,
And his work is worth a look because it's the same idea. One of the first observations they made is that experts and novices pay attention to different environmental cues, um, and even that's just an interesting observation because then you can say, okay, well, why was the attending spending their whole time looking at the monitor, and the novice was looking at the patient's foot the whole time? Like, why was that? What's the difference there? And what's the difference in terms of what's the relevance in terms of what people are paying attention to and their ability to execute? And so there's lots of interesting work. Dan Howes is the other research there. Adam and Dan have done a lot of interesting work on pupillometry and eye tracking, speaking to that notion of cognitive load and what experts are paying attention to and what you ought to be paying attention to. And I think, as the three of us are probably alluding to, then what skills do you need to bring to bear to say, okay, if your attention is faltering or wavering, or in your mind, if you're beginning to think about something extraneous like a socioevaluative stress, how do you bring yourself back into focus? You can focus on executing the problem at hand.
yeah, and there's excellent research around that. Also, gaze behavior in police officers. There is from Finland recent dissertation about gaze behavior between novices and experts. Also, the same you're talking, and yeah,
Mhm.
you can just call it meta awareness. I think it's a better word than
Mhm.
metacognition. You
Mhm.
can just train yourself uh, to become aware of where your attention is. And it
Mhm.
seems that even that notion is, how do you call it, is strong enough to get you back into your focus. Of course, there are
Yep.
additional skills like breathing and grounding and even use of the inner coach,
Mhm.
to coach yourself through the movement and so
Mhm.
on. Yeah.
Mhm. Yeah, and I mean, for me, I think you asked earlier about my practice, and I don't know if I really answered you, but the one thing that I find myself doing most frequently in a stressful situation is exactly that, bringing myself back into focus on the problem at hand. Because you can sit there in a scenario and be sort of locked in and dialed into the problem. Let's say it's an airway challenge, and you're not the hands-on airway person. You're sort of supervising and monitoring and responsible for oversight, and your mind can drift into something like, you know, not necessarily good thinking about failure, but oh my God, what happens if we can't intubate? Not like planning for
Yeah.
failure, but starting to spin around the notion of, this might not be successful. And that's where I find things like a cue word, a trigger phrase, a deep breath. And for me, and this might sound a little bit odd, but for me, it's very much just physically feeling my feet on the floor, feeling
Yes,
myself planted on
exactly.
the
Yeah,
floor,
yeah.
suddenly brings me right back to where it is I'm supposed to be. And I'm getting better and better over time at saying, okay, you're drifting. Come on back to reality for a second. Um, and recognizing, okay, whatever this is, it's a solvable problem. That's the other coaching phrase I like to tell myself. Like, there's always a solution. This is a solvable problem. It just might not be the solution you want. There's still a solution. So those sorts of things, yes, it's quite true. They do tend to sort of refocus you, or you might broadly speaking call it reframing, but it is a matter of sort of capturing your own attention and then focusing it back in on the thing it is that you think you need to focus on.
Yes, and
But
Judith Ensign, Ruben, sorry.
sure.
Judith Ensign, also from Toronto, she did a study about the reset, refocus, respond. It's a breathing study, but it's the same. You know, the attention research shows us that even professionals, how do you call it, are mind wandering at 30 to 50% of the time than even a surgeon. So this is normal. This is your normal mind, and
Mhm.
this is not to blame
Yeah,
your mind, but
you can't be
y-
locked in all the time.
no, you
It's
can't be
exhausting.
focused. You can only refocus. Yeah,
Mhm.
and to understand that that's happening and to refocus again, that's a important skill. Ruben, sorry, I just interrupted you.
No, I was interested because what you described about the intubation, it's very human to feel that,
Mhm.
to have that feelings, but be aware of that feelings is to go back to the question of Eric. Do you need to stop your scenario to make you be aware of that feeling? Because the first step is be aware that you have negative feelings and that influences your decision. Um, and do you need to stop the scenario to yeah go into depth in your emotion and then do your rapid cycle and continue again? Or what do you think about that? That is stopping because the first step is recognize your own emotions will influence
Mhm.
your skills before you do a
I mean,
trick like you
maybe
described.
it might be a wishy-washy answer, but it depends on the goal of your scenario. If that's your goal, if you really want to build up sort of micro skills, in the area of attention and focus and emotional regulation, yeah, I don't think there's anything wrong with stopping and saying, okay, let's pause here. What are you feeling? What are you thinking? Making an observation like, I noticed you went in and started whatever. Yeah, I notice a lot of our docs at our center have like one particular thing that they feel they need to get their hands on in order to. It's like a calming behavior. One of them goes and starts to settle up the rapid infuser, even though that's probably not maybe what needs to be done at the time, but it makes them feel better, so that's what they do. You can make that observation and say, I noticed you went off and sort of were hands on immediately. What was your thought process? What were you thinking, and what were you feeling? Cool. Okay, talk a little bit about that. Let's rewind it again. And this is, I guess, sort of standard advocacy inquiry sort of form of debriefing. But I noticed that you were off doing this, and my observation is that that the patient required something different. Talk to me a little bit about the disengagement between the two, or what were you thinking, or what were you feeling? Talk about it, and then go back and do it again. I think there's a very plausible way to get it done. Again, it just depends on what the goal of the scenario is, and then by extension, fidelity is kind of a four-letter word in simulation. Functional task alignment is probably a better phrase for it. um, there's no need to maintain pure psychological fidelity through every scenario always, if that doesn't suit your training goals. Meaning, it's okay to interrupt scenarios and start and stop, or provide feedback, or do a rapid cycle technique if it seems to be the case that that's the best technique for what it is that you're trying to accomplish.
Question
I,
answered?
you you both. I have to apologize. I probably will have to sneak off shortly.
Yeah.
And I feel like I'm repeating myself, so I apologize for that. I said the same thing a
No, no,
few
no,
times.
no. I wish, how many minutes do you have for just the last
Either
question?
sure, another 5 minutes is fine.
5 minutes. So the things I wanted to ask you, of course, I wanted to talk about implicit coordination in teams.
Mhm.
The different tactical pause is a great concept you mentioned, but I think to end it off, I'm very interested in how do you stay healthy and happy on long term as an emergency doctor, because we can talk a lot about stress and stress, acute stress and stress in performance, but how do you stay healthy yourself and also for the next generations of doctors? Do you have any thoughts about that?
Sure. Yeah. I mean, it wouldn't be, it would not be an exaggeration to say I've gone under a pretty significant shift in the past, I would say 5, 10 years in terms of what my focus is and how, sort of how I keep well. Um, I think for me, I had to realize that a lot of the things that I was reaching for professionally in terms of academics and career um, were, I mean, talk about social value of stress. They were just, they were not things that were making me happy, and they were introducing stress because I was constantly comparing myself to others in my profession and other academics at my institution, and never really feeling like I was measuring up. So somewhere along the line, I realized uh, that's just not for me, and I'm going to do less of it. So maybe the first sort of general bit of advice is take the things that really aren't making you happy and try and cut them out of your life as much as possible. That's easy to say. You know, we hear a lot about the sort of 80-20 rule. You still have to do 20% of, you know, the stuff that you just don't like. But ideally, your life is still 80% of the things that you really do. But I've done a whole lot less of that. Um, there were things in my daily life that I was not paying attention to that I realized were really important to me and I needed to do more of. Um, Specifically things like exercise, music. I used to play the piano a ton when I was younger. I sort of gave it up. I wanted to come back to it, but you know, never really committed to coming back and practicing seriously. And reading, those boilerplate, those are the three things that I was doing less of that I needed to do more of. I've sort of made a commitment to myself that of those three things, I need to do at least two every day. Practice and exercise, exercise and reading, whatever happens to do. A great day is all three, but the point is making time for those things. And even if it's just, you know, I have 20 minutes to go and practice something really challenging because I got a piano exam coming up, you know, that's enough. And reading a little bit before bed, that's enough. But those three things I have to get done. And of course, that's in addition to, you know, the things that you really need to take care of in life, your friends, your family, your partner, your spouse, your relationship. Those are all up here. The things that really fulfill you, that are important to you, are essentially here. And I think what I've learned over time is that, you know, as much as I like my work and I like the work that I do and I like patients and I like patient care, 15 years ago, I would have said that's who I am. Now I say that's what I do.
Mm.
And it doesn't make it any less important to me. It's just not who I am anymore. It's a part of who I am. And I think that's an important distinction. When I leave work, you know, it's not as if I'm not committed to improving and doing better and getting better with my career. This is far from being burnt out because I'm, you know, still very committed to my job and still very committed to sort of getting better as I progress and as I become more expert over time. It's just not everything, and it's not the sole thing that makes me who I am. And that's been an important, a really important distinction for me. It allows me to sort of leave work and leave a lot of the work behind me and go and focus on other things. Whereas in the past, all of those other things kind of got the leftovers, and work was essentially everything. I'm fortunate to be able to say that, obviously, because you know when you're 2 years into your career, you can't necessarily just do everything you like and nothing that you don't like. You know, I'm 15 years in now, so I've got more flexibility essentially because I can. So I realize I'm fortunate in that regard. But I also wish I'd started off on a different premise and maybe would have wasted a little bit less time and maybe had a better 10K time and been farther along with piano than I currently am. But it's a work in progress, and it's hopefully it's an optimistic tone to end on to say I think I'm a lot happier now, 15 years in, than I was, you know, 5 years in.
Any closing thoughts about that, Ruben?
No, I like it about 10K, but and also about the family. But thank you, Christopher.
Well, thank you. It was a real pleasure to speak with both of you. Thank you for the invitation.
Yeah, thank you so much. And I learned a lot and very inspiring, and we will follow your work. Is it possible to post a link to some articles like 0 Point Survey and
Yeah, of
so
course.
on?
Yeah, of course. If you need the articles, let me know.
Yeah,
Yes, we can send all
great.
of that. One of the earlier articles, sorry, this is maybe off the record now, but one of the earlier articles that we wrote was called Beyond CRM,
Yeah.
and it links to maybe some of the earlier things that we were talking about, which is what do you need to do in addition to just crisis resource management. That kind of got a lot of the conversation for Andrew and I off the ground. And then there's a blog post out there that we posted on MCRIT about kind of our thesis for, it's called, undoing the shackles of bad design or something like that. But it's how the sort of design thinking ought to be overlaid over top of everything else that we're already talking about.
Well, thank you
But
again.
yes,
And Ruben, also thank you for all your great work. And we will
enjoy Athens.
I enjoy Athens.
Yeah, thank you very much. It's nice here. Yeah.
And thank you to all the listeners. And I will close the podcast and I will say goodbye off the record to Ruben and Chris. So
Looking
until
forward to
next
it.
time.
Thank you both.
Thank you very much. Have a good time.
Take care.
Bye bye.